when you get a message on your phone, can you forward it? You know how to do that?
You can copy it.
You can copy it.
Yeah, so for instance, you can do this.
Yeah.
Hold on it.
Yeah. Copy.
Copy. Let me see if there is more things to do. Here we go.
Oh, you can. Oh, wow. Okay. Good. Thank you.
Parking is becoming a mess here. Well, not it is. Today's the first day I ever had to park under this building. I could not find a parking spot.
It's very variable. I usually park down past the trophy place on the other side of the street. You know, on 9th Avenue.
Yeah, but now they're closing.
I know.
They have these signs up everywhere making even, the sneaky little parking spots we always could sneak in there to block them off.
Right. I found one across the street, right outside the door.
Zoe, the young woman who's often at the door, she told me she parks by the hydrant.
Oh.
And just forgets that there's a hydrant there, just gets away with it and figures she can talk her way out of a ticket because she's a young woman. I didn't say that, but I guess.
Fun for President's holiday weekend?
The first is Valentine's Day.
Oh, I know. That's just a made-up holiday.
Oh, I know. Christy just told me it's very important. I have to
Oh, it
remember
is?
it.
Oh.
Yeah.
I think it is. Yeah, it is. We don't get a day off work for it, so.
That's true. Whenever there's a holiday on a Monday, it poses a problem for these sessions because the university is closed.
Right.
And so getting everything
Reminder
arranged,
out.
getting the handouts printed, getting the announcements sent out, which is usually done on a Monday. All the people here have the day off.
Yeah.
So I have to make sure it's done on Friday, which it gets harder. People don't, everybody does everything at the last minute. So hassling a speaker to get their handout ready by the previous Friday doesn't always work. Nick, are you going to the meeting? You going to it? No? How are you going to it? A large number of people not going.
Where is it this year?
Orlando.
Yeah, you're welcome. Yeah.
That's part of it.
I was just there
Yeah?
in Orlando
What were you doing there?
for a wedding for one of my nephews.
But you weren't out by the convention center. No.
Well, I was near. I wasn't too far from that, where I stayed.
I was in St. Petersburg not so long ago.
It's nice to play golf in the sun.
I'm sure.
I'm so tired of this rain. Now it's not raining; it's just cold. They close the greens because it's too cold.
Break the grass.
Yeah.
I think it's better than rainy, right?
Yeah.
Oh yeah, this is when it's raining in Gray, that's when it's the worst here.
Yeah. It's
It's cold.
It's cold.
Okay.
It's okay, It's cold. Just wear double layer and you can go out.
It might be coming down. Just FYI.
So I was called.
You were called? Oh, how was the cold?
Not the call, the call. Without the
Call. Oh, it's okay.
Okay.
I got, you saw the two UW principals yesterday.
Yeah, I see the email that everybody complimented our efforts.
What do you?
It's an email.
Oh. Then all of a sudden, all the teams, they were testing. No, I mean, it's like 30, it's like 4 weeks. It's like every day.
Nick, you have any trips coming up? Europe
2 weeks, Italy. And this summer we're going to take a river cruise down France and Germany. Between Amsterdam and Avignon. You go up the Rhine first, and then they bus you over to the Rhone, and then come down the Rhone.
Which company?
CROISI, Croisi River Cruises or something. 11 days. It'd be nice.
We did Danube.
Yeah,
What's nice is you're in the same, you don't have to move.
that's right.
The boat moves, you got the same accommodation.
That's what's nice about it. Last year we drove 2,100 miles in Spain and Portugal. They wiped me out. I'm not going to do that again. Actually ended up in the hospital.
Back here in the States.
No, back in the transition. I just had I had a sinkhole episode.
So where are you supposed to park?
Yeah.
You know what? All those construction workers all have big trucks, so they all take up like 1.5 to 2 spots.
Where did you?
I got here, seriously, I got here at 6, I left early. I got up at 5:30 this morning because I blah, blah, blah. And I got down here by 6:29, and I've just spent the last, I called Scott and said, if I can't, I'm going to do one more pass. If I can't find a spot, I'm going back to the office.
Well, I actually had the same problem. I parked under the building.
Yes.
And
Can we do
so-
that? I didn't think it opened at 6.
No, it's open. I'll mention that when I stand up here. But yeah,
Our speaker's not going to be
the
here.
gate is up, and all you have to do is take a ticket, and I think it's only $2 to leave. Anybody ever?
$2? That is.
I mean, I can't get up any earlier. I'm not getting up before 5:30.
Let's say
$2?
this.
It's a little crabby.
I'll cover the parking one way or another if you have to park. Not me personally, but our friends in industry.
It's just, it's too much.
Right? I can promise you money, can't I, Christy?
I can start my day
Work on that.
driving around like a mad woman.
Gotta get creative here.
I'm mad.
I mean, because I don't want Leslie yelling at me. Like
God!
that.
No kidding.
She makes a good
Oh,
face effort to come
my
here.
Italianness is coming out right now. It's like, "Rawr!" You know, I'm Italian. It's like, God. I called Scott. I'm like, this is it. I'm like, remind me to never go again.
No, I don't want that attitude.
I know. I mean, in New York. What time do you leave? Oh, you park in the Tesla parking lot. Yeah, you're
Special
sneaky.
spot.
You have to have a Tesla to park there?
Yeah. No, I don't. It's
Is
just
anybody there? No one's there to police it.
no. It's
Oh, that's a good idea.
Yeah, it just looks like his car's getting serviced.
Yeah.
They park where all the service cars are.
Oh, where is that? Right down the block?
4 blocks over.
I think what happened.
You know where Tesla's on?
I know where the showroom is. By the showroom?
Yeah, it's right around the corner from the showroom.
has an empty.
Oh. Can I get you?
I got my Diet Dr. Pepper.
Let me mention that.
Do I have
No,
another
otherwise
story
I won't have a
You
place to
do?
park.
Why, aren't there
You know,
other spots?
Mrs. Pricell?
No, there's 2 restaurants right there.
Got it.
There's
She saw
3
both of
slots.
your
there.
boys.
I think
Oh,
that's a
Sandy.
Tesla slot.
Miller?
Yes.
Yes, yes,
She's married to Greg Miller,
yes.
who sits 2 seats away from me in my choir.
Oh, seriously?
Yeah.
Aw.
Yeah. So I met her and we started talking. So,
She's lovely.
she is very
She
lovely.
is. I have so much artwork in my house from her.
Yeah.
It's all about
She
her.
does animals, she does pets.
She does. Well, she was the art teacher at New Ridge,
Right.
and she is she's fabulous. Anyway, and she quit. I think she retired, and then now she does stuff down at Magnuson. She's one of the
Yeah.
people
Some people
that's.
are very
Oh, she's,
Greg is very good.
yeah.
They're going to Italy.
Oh, they are.
I'm going to Italy with the choir.
Oh, nice. Oh, good.
So,
I run into her every once in a blue moon, like up
yeah,
at the grocery
she's really
store.
nice. He's very nice.
Oh,
Really
good.
terrific. I'm going over to their place on Sunday after church
Okay.
to sort of have a pre-trip
Yes.
get together.
So where are you going in Italy?
We're going to start off in Florence
Nice.
for 2 nights.
Okay.
Going to sing in the cathedral. And then we're going to stop in the Sisi. No, stop in the Siena.
Okay.
And then we're going to Rome. Sing at the Vatican and all the churches. It's the usual stuff that we do.
Yeah.
Great.
Oh, it'll be great. Oh my gosh. And then will you stay any longer?
I am.
You should.
You know I would.
Well, I would. If I was going to Italy, I would want to stay a little longer than the trip.
What I'm going to do this time, I have a close friend that I've known since I was there on my Fulbright in '64, Franco. So we're going to take a train up to Vestibular outside of Venice, rent a car, and we're going to go to Trieste
Oh, yes.
in Slovenia,
Yeah.
and all the way down to Sarajevo,
Oh, nice.
and then to Zagreb and Ljubljana, and then come back. So I've never been in those
No,
countries.
no. Oh my gosh.
So he hasn't either.
Oh gosh, that's great. Oh, I know. Well, my baby graduates from college next year.
Oh my goodness.
I know. Can you believe it? So we took Jack to Italy. So I think Matt, I think maybe we'll go Spain. I'd go back to Italy, but I think maybe Spain. Yeah, I've never been there.
So you get around the people. I love it.
Yeah, I think that's our. I have to. I have to start speaking it out loud so Scott can get his head around it. I hope our speaker shows up. That's the only reason I came. I heard him speak one time.
Are you seeing patients at all
Oh yeah.
at Northgate?
No,
Yeah,
I literally
I
sat
one day a
down
week.
Sunday from like 9 a.m. I didn't get up until 6
I have
p.m.
someone who referred to that.
Yeah. Yeah. Yeah.
Well, because she kept emailing me what happened. Oh, whatever.
One of the teams called me yesterday
Yeah. Oh, for a consult?
for the one that you asked.
Where did you end up parking? The car away?
Oh, I'm gonna have to leave early because I won't even remember where I parked.
Saw that patient I covered before.
I'm way past the Amazon building. I'm like 3 blocks down.
It's the real deal.
I don't know. This is reasonable.
Well, I didn't know that. I thought it was open. I'm driving around like a mad woman.
Last year we had the door open.
Yeah.
Well,
Oh,
no, there's restrictions.
Well, I just, because
Yeah, but it's just, yeah, no.
I would assume.
See, I thought the compression only was 7, but now Glenn says we can park there.
Because I guess before it's always been on
Back
it's
to March.
working on.
Yeah, that's interesting.
So maybe they can check.
Well, I guess it's
Not the one from yesterday.
Yeah, because I've got my access card. And then I just that was just fortuitous that
Yes. Yeah. I can't do
How about you?
Good. My dad retired last Thursday.
Is he not going to come anymore?
I don't know. I think he is. Len will make him.
Hi, sir.
Yeah, it's
I got here.
hours of the day. You have to figure out what
Drive around.
His full-time job is going to be driving my mom crazy.
interesting.
they were working up there.
Maybe it stays up there. That's particularly lucky.
He's talking about
The car
under this building?
Yeah.
Under that.
No, this building. When I got her, this they turned it down. And I assumed it was still up. But no.
No, he's saying they're
Thankfully, Joel was behind me and went over. It's hard to put it up. And then once you can,
I haven't. You met with Harvey.
He changed their mind.
Or, yeah, I guess like,
Oh, so we're gonna have to, the parking's becoming so impossible.
she wants to figure that out.
Let me look through it. It's Thursday. It's Thursday.
yeah.
Okay.
This was a good day.
Yeah.
Yeah, it's up in my office. That should be. Will you do me a favor? Can you email me on Thursday? Yeah. It's my one.
Oh, she's still no. I got
No,
you.
but I should be able to
Still
get
there.
to it.
Okay. Thank you.
Yes. Yes.
I don't know.
Yes.
Actually, I think the Harvey.
Good. Okay.
I'm not sure.
I have to submit for
Oh,
the grant for that, so.
Probably Harvey.
Every other.
I love that.
It's a good one.
Hi, Bill.
I was up at Whistler this past
I
weekend.
know, it was a bummer.
Up there, so
You know what? It's funny.
it's not where it's going now.
Well, I only went
Weekend on
Oh, okay. We'll be back at
It's cold. It's not snowing.
We actually skied under the snowmaking guns for a while.
My sister-in-law turned 60
That was actually
in December, and we did a ski trip like the week before. I just felt like it was a little too much.
Let's go ahead and get
Too much plan. I'm not retired yet.
First order of the day is parking. I know it's becoming impossible, and it's basically dissuading people from coming here with the opposite of what I want. So I parked under the building today for the first time. So anybody in the room or outside who doesn't come just because parking is such a pain, we'll try and make sure. The gate was up when I came. I just drove right in the building, but Frank tells me when he was there, the gate was down. So Bill talked to management here and tried to make sure that the gate is up by 6:30 in the morning. The guard at the front told me that it's free parking till 7:30. So basically, if you leave at 8 o'clock, it only costs you $2. So you don't have to drive around in circles. So we're talking about the parking garage under this building, which is on Republican, just slightly towards Dexter. Yeah, Dexter would be the next street to the west. So it's a little west of where we're standing now, and you enter it off of Republican. And $2 is too much. I'll figure out how to reimburse you. Or our friends in industry will help, I'm sure. Don't record that. Just one other thing. We're going to have a social function get-together on March 4th for those who are going to the meeting in Orlando. So you've gotten emails. If you haven't RSVP'd, if you're going to go to the meeting and want to attend, let me know, because I have to make final arrangements with the restaurant and try and keep it to just $50 a head. Today's presenter is Dr. Michael Mallahan, and he's going to talk about hearing and balance function, a really valuable and pragmatic talk, something I don't think any of us are really taught in medical school, and very useful information because patients think that these are allergic conditions and think we know something about them, and it's better if we do know something about them. So thank you for battling the traffic. Good morning.
Good morning. Well, appropriately so, my allergies are kicked up today, so I'm dripping and congested. I may get some advice here later. See if I know. Disclosures. My first disclosure is I'm a Seattle Sounders fan for life, and any Portland Timbers fans need to leave the room immediately. My background is I grew up here. Went to school locally, undergraduate, graduate school, and then went out to Arizona. Joined in otolaryngology practice with Pat Lynch back in 1982. Started the Hearing and Balance Lab from '94. I walked in the door and, out of school and was faced with a bunch of dizzy patients that I really had very little exposure to during school. So graciously, Dr. Lynch sent me off to Chicago for a 6-month sabbatical to learn about dizzy patients, and I'm still learning more and more stuff every day. Every patient I see, especially Dr. McBride sends to me, I learn more about patients. And every time I see a referral from Dr. McBride, I know I'm going to have a tough nut to crack. I see newborn infants to adults. So I started a newborn hearing screening program quite a while ago, and now I have almost have patients that I identified as deaf as infants now are starting to have children of their own and getting screening. I also take medical and surgical teams to Guatemala twice a year, ENT, otolaryngology surgery, and provide training to Guatemalans on audiology care. We now have 15 Guatemalan audio techs serving around the country, which is most of my distraction. I take my students down there every year to get some flavor and get some interest and get a lifelong passion for service. What's an audiologist? Well, we provide assessment of infants to adults for hearing and balance related disorders, and we serve in different areas, both at the university, clinical, industrial work. The Boeing Company has high-level noise exposure, but within Washington State, there's a large opportunity to damage your hearing in work. About 12,000 of us throughout the United States. Why? As the baby boomers get older, we have a higher need for audiology care. Quite a bit of hearing loss is found. Hearing loss is the #1 birth defect. You find 6 per 1,000 infants have an educationally significant hearing loss. 1 per 1,000 is deaf. The rest have hearing loss is going to have a consequence for their academic advancement if they're not identified early and monitored and treated and assisted. As we get older, we start losing our hearing, and I am a poster child for that. I currently wear amplification myself. I'm glad I didn't go into cardiology because I had vestibular neuritis, I have tinnitus, and I have hearing loss. So that's my claim to fame and my passion for telling patients they don't have it so bad.
What's the cause of the deafness in children? Is it just congenital?
Half of it is genetic. The other half we don't know why. It could be maternal infection during pregnancy. It could be nutrition issues, a number of things, and postnatal issues that come up. Anoxia at birth, bloodborne.
Not one single thing, it's a gamut of things. Then.
So a wide variety of things. But there's a big bucket that we don't know. Kids show up with malformed cochleas, and there's no reason to describe that. Dizziness is a very common component, and it's a big thing that a lot of money is spent every year in dealing with patients with dizziness. Most of that money is spent in the ER ruling out a stroke or a heart attack when it's just a vestibular incident. So let's talk about anatomy and physiology real quickly. There's the outer, middle, and inner ear. The outer ear is comprised of the auricle, the external auditory meatus, and the tympanic membrane. The tympanic membrane has 3 layers of skin: the epithelial layer, the fibrous layer, and the mucosal layer. The middle ear space is lined with mucus, and it's constantly absorbing oxygen. Therefore, the need for a eustachian tube to provide ventilation. The eustachian tube opens up about 300 times a day to provide oxygen into the middle ear space. Tissue is absorbing oxygen constantly and has to be replaced. If it isn't replaced, then it creates a problem. It sucks fluid from the surrounding tissue. The middle ear contains the ossicles, the 3 bones, the 3 smallest bones of the body, attached to the eardrum and to the oval window leading into the inner ear, the cochlea. So common problems with hearing that occur are otitis media, which you probably see quite a bit. So it's just an inflammation of the middle ear mucosa, causes the eustachian tube to swell. It could be the adenoids get inflamed and block off the opening of the eustachian tube. That causes negative pressure within the middle ear because the oxygen is not being replaced. That absorption occurs at a period of time. The negative pressure in there creates an earache. That earache lasts for a few hours. Could come and go, but it's more commonly there for a short period of time, and then fluid is extruded from the surrounding mucosal layer. Serous fluid fills up the middle ear space and creates a temporary hearing loss. The longer the fluid is there, the more impact it has on the hearing. The fluid thickens over time, can create hearing loss as great as walking around your fingers plugged in your ears. And that creates a significant impact to a child in language learning and in school. That is easily treated, typically by time. Sometimes throwing antibiotics at the condition is thought to provide some benefit, but only gives a 25% chance of things getting better than letting things resolve on their own. So the effusion persists for a period of time. If it lasts more than 60 days, the likelihood of it going away on its own is very low. And so the option at that point is to get the fluid out of there to restore hearing, and it's simply taken care of by slicing open the TM, suctioning it out, and putting in a pressure equalization tube. That tube then becomes the ventilation system, becomes the artificial eustachian tube to dry out the system and allow restoration of hearing. And that can occur walking out of surgery. So you get the tube in the ear, the child immediately hears better. The fluid can persist for a while, the fluid can plug up the tube, you can have all kinds of complications from that. But commonly, it is a very nice solution to long-standing middle ear fluid. It's not a solution to short middle ear fluid issues. Children that have chronic middle ear problems can be allergic children. So they have chronic inflammation, causes increase in mucosal secretions, and causes repeated hearing loss. Children with chronic otitis media have a phenomenon called auditory deprivation. You also, as an adult, can get auditory deprivation by having cerumen accumulation in the ear canal. Ear canal secretes a couple of different glands, secrete an oil, mixing with dead skin that sloughs off the TM in the ear canal, and that can plug up the ear. When the ear is plugged up and the fluid is there plugging things up, it decreases hearing acuity. The brain is not getting all the data, and if it lasts for a long period of time, you end up being deprived of auditory information that then can have long-standing problems with children in school. Even after their hearing is restored to normal, they had a long period of time without access to sound. The brain goes on to other things, tries other things, and even when hearing is normal, they have complaints of difficulty with hearing. You see adults all the time that complain about difficulty with hearing. We see normal hearing acuity by some measures. Same thing can happen with cerumen occlusion. You clean a person's ear out, and all of a sudden things are way too loud. And they say it's way too loud for a couple of weeks until their brain's able to get acclimated to normal hearing again. Same thing happens with otitis media with children. So you're going to have a kid that talks loud. You're going to have a kid that likes to sound up louder on the television. You're going to have a kid that says what still when they're hearing audiometrically is perfectly normal. So it's an interesting phenomenon with auditory deprivation, either short-term or long-term. It has long-term impacts. Otosclerosis is a calcification commonly around the crust of the stapes. It is a cementing down of that bone. It starts off initially as otospongiosis and then hardens over time and stiffens the stapes and causing it not to move freely, and that dampens down sound transmission from outside to inside. Inside things are perfectly fine, but if the stapes is not moving freely, That creates a hearing loss. And the only solution for that are there's three solutions. Do nothing, which commonly patients do. It creates a significant loss of hearing. You put a hearing aid on. Hearing aid restores hearing to a very good hearing aid candidate. All you have to do is make things louder because the cochlea is still working perfectly fine. Other option is very successful is do a stapedectomy. Take the stapes out, replace it with an artificial prosthesis that then restores hearing function. Occasionally, you can get smacked upside the head, suffer an injury, and displace that prosthesis, and then you have to go back in and put it into place. Hopefully, it doesn't go through into the cochlea and cause permanent damage. It's typically a temporary thing that can be fixed. Talked about cerumen impaction and the consequences of that.
There's a pointer up there. If you use the mouse, if you want to point to structures.
Very good.
Is that true, Jay?
Yeah. So other common hearing losses, the most common things that happens to folks in my neck of the woods is hair cells start laying down on the job. So the cochlea is lined with a membrane, and sitting on top of the membrane are hair cells. There's 3 outer row hair cells and there's 3 inner row hair cells. And you can see here, with my pointer, here's the inner row, here's the 3 outer rows. Here's a flip of that. This is the inner row hair cells, still fairly in good shape. But you see that the outer row hair cells are either missing in action or laying down the job. So that sound, when it travels in, sound travels through in a fluid wave. Hair cells are not standing up, the fluid wave travels through. It has to be a larger wave, which means a louder sound to stimulate those hair cells. So someone with damage to the hair cell structures can't hear soft sounds or moderate sounds. They have to be much louder to stimulate the hair cells in the inner ear. Noise is a common thing that causes damage to hair cell function. Noise comes as a tidal wave of fluid displacement, which then causes an inflammation of the Reisner membrane that the hair cells sit on and causes a reduction of nutritional vascular support to those hair cells. Temporarily, with the inflammation, damages the hearing. Your ears are plugged up. After going to the AC/DC concert, to the older folks here, they walk out with a plugged up sensation in their hearing. That is the inflammation of the tissue. The inflammation goes away, the hearing gets better, but you may be left with a ringing or a buzzing or a humming noise in the ears, and that's due to structural damage to the neuronal support system. Repeated exposure to noise over time causes the hair cells to die off just because of reduced vascular supply. Repeated exposure causes that damage. It causes them to go away. That requires people to require more sound amplification. Presbycusis is all of us getting older. Hair cells decrease in their sensitivity over time, like our vision. It affects our hearing. And the hair cells change as we get over. Ototoxic medications also damage hair cells. They may damage only the inner row hair cells, which causes a discrimination problem. Other things will damage those hair cells. But once they're damaged, they don't get better. For humans, we don't have the ability to morph our support cells and turn them into sensory cells. Birds do. You damage a bird's hair cells and they grow new ones. And for the last 30 years, we've been trying to figure out how to crack the code on how to get those support cells to morph into hair cells. Birds have not released the information yet at this time. But we hope that in the future that they will. However, we have found there are medications that you can take that toughen up your hair cells so that when you are exposed to high levels of noise, your cochlea does better with loud noise. So there's medication now that's now coming out. It's been researched for a long period of time. There's a couple of medications going to be released in the next couple of years that someone takes on their way into the job during the day. They pick up the earplugs, they take their medication, and they preserve their hair cell function, which is a nice thing to offer to military service individuals that don't have the option to say, hey, wait a minute, stop firing, I got to put in my earplugs, and then we can start firing again. So it's medication that can preserve hair cell function. It's a nice thing that's coming about here with research. But we are not going to be able to restore those hair cells yet.
Since you brought up other species, when I was looking at the anatomy of the bones in the middle ear, I was wondering if other mammals have ear structures like we do. That seems to me like a Rube Goldberg kind of way to have your middle ear, to have three bones that have to function. Like, who set it up that way? And do other mammals have the same ear structure that we do? They all work the same?
They do. Many of them do. Cats have a little bit different structure. They have only 2 bones in the middle ear. Chinchillas have 3. We use chinchillas a lot for research. Zebrafish are a favorite current study mechanism for looking at medications because of the hair cell response. Damage zebrafish hair cells the same way as it damages the cochlea. So you do use animal models for research. Zebrafish are a good example of monitoring ototoxic effects of medications. Okay, so here's a dangerous topic for me to introduce here in this building because I really am not the expert. So as I talked about before, inflammation of the system causes more mucus production, which causes middle ear mucosal tissue to release fluid. You get inflammation in the sinuses. You get inflammation in the eustachian tube. That creates a problem with air transfer. Most of these are middle ear related phenomena. There is argument about cochlear impacts from allergies. You know, we have the age-old discussion about Meniere's disease, and is it an allergic reaction to food that you're taking, or is it some other kind of reaction? There's still some folks that hold on that's an allergic reaction. Migraines produce effects to the system, but more commonly vestibular function, more of the dizziness side of things. The most common allergic reactions affect the middle ear and outer ear. Itching in the ears is a common allergic reaction. But that is my expertise in that area. I welcome further comments on patients of yours that complain about hearing loss and allergies.
Are those who are pediatricians in the room? I mean, I'm an internist, so I don't know, what kind of impacts do we see in kids, allergic kids early in life? Anyone?
Well, I mean, I think it's well described, the impact that it has with chronic effusions, and also obviously increasing the chance of getting secondary infections when you put a virus on top of that. And the good news is the anatomy gets better.
As the skull gets bigger?
Yeah, well, literally the eustachian tube angles change and that sort of thing.
So my earlier comments about the effects of antibiotics in miliary effusion, are you?
Yeah, that remains.
What's your advice to parents?
Well, it remains very controversial. I mean, if they're clinically have pus behind their TM and so forth, certainly I'll treat them. But I think generally, just like, watching a viral course, that it makes sense to watch and wait. But obviously not for 4 years. Because, despite what I said, sometimes if allergy worsens and so forth, you've got that 1 to 4 year age group. It's very critical for developing language. And like you said, so often the quandary is you have a kid with recurrent otitis, And the question is how much is due to anatomy and how much is due to allergy. And obviously
And viruses.
and we answer that. Well, yes, or sinus disease actually is a very common reason for recurrent otitis, untreated sinus disease. So it's balancing all of those things, knowing that if you can, eliminate those other things, maybe you'll tide them over till they literally grow.
What's the anatomic relationship between chronic sinus disease and middle ear disease?
Well, I think the most, just from the ENT people, it's you get, when they're laying down, you get drippage on the adenoids and you get adenoiditis. See, it's like an abscess there, and it can track right back through the eustachian tube, as well as cause swelling. Common finding.
I guess one opinion I'm going to share that may or may not be shared by everybody, but I think is important, is that treating middle ear effusion, getting the kids better sooner, I'm a big fan of. Just letting effusion sit there and say, oh, it's going to get better. By the time they're 4, we're not going to have a problem. The problem is the before they're 4, we're going to end up with possible long-term problems. So I am, as with my own children, the moment they had effusion that lasted more than 3 weeks, I'm putting tubes in their ears. I'm not putting them in, the otologist is, but I'm a big fan of tubes. And the argument is, well, you put tubes because of scarring on the eardrum. Well, it's amazing how much scarring you get on the eardrum by not treating the issue. And the consequence of tubes in the ears is a hard argument to say that putting tubes is going to cause long-term problems. The consequences of not putting tubes is going to cause long-term problems. So I'm not here trying to promote surgery, but I am here to promote good hearing in young children, which is absolutely critically important. And I think that many physicians tell parents, it'll get better with time, we'll keep an eye on it, we'll wait. Parents come in begging for help because they've had this watch and wait scenario going for a long period of time. That's my sidebar opinion. So I'm a big fan of normal hearing children.
Is there any benefit of tympanocentesis versus just putting in a tube?
You're asking the wrong guy. I think that you're going to get 24 hours of relief. You really need to ventilate that middle ear system and getting it dried out to restore hearing.
There's
I'm not sure that
a group of people that argue using that to determine if antibiotics will be useful also. So it's therapeutic that also answers that question. And it is pretty simple to do, but maybe not in a 2-year-old.
Yeah, sampling the middle ear fluid and determining how to treat it is maybe another option, but I think that getting the middle ear clear is, I'm a big fan. All right, another part of my practice that I am learning something new every day with every patient I see is a magical mystery tour. It's balance problems. If you have never had a balance problem, you're a very lucky person. But I'm going to guarantee you're going to get an opportunity for a balance problem before you pass this earth. And it's no fun. It is absolutely miserable. And those that have chronic balance problems are miserable people. They have no fun. And so my job is to try and identify what can be done and how to get them better, not fixed, but better and better functioning. So some things are short-lived, some things are long-term. I'll talk about balance problems. Tons and tons and tons of people have a sudden onset of spinning vertigo. They are carted off by an ambulance and paying a $500 bill for that trip to the hospital because they can't drive themselves. They think they're having a heart attack or they think they're having a stroke. They go into the ER. Some simple measures to assess their function can be done in the ER, but they're commonly not employed. Commonly send them off for a CT, send them off for an MRI, get an ECG, get all these measures to make sure that they're covering the bases. and thousands of dollars to spend on that ER visit. And the bad news is that real diagnostic assessment is not completed. They are then sent home with meclizine, which is the second worst thing that happened that day. They're home and miserable for a month, and they finally get in to see somebody, and then they get proper care. But they delay diagnosis, they delay treatment, and they prolong the misery. So it's a very common thing that occurs, folks. The older you get, welcome to a better opportunity to have a vestibular problem. So, numbers are good for you to have a problem when you get older. The bad news is, and I see a lot of patients that are in the 80-year time frame, 80 years and older. The good news is we're living longer. The bad news is we're not always living better because we're living longer. And people that are in their 80s are told to get a cane without any instruction on how to use it. They're told to do all these things, or not told to do anything. And they end up ending up with a balance problem, ending up falling and breaking a hip. And I scare my patients into doing what they need to do by giving this stat. After your 80th birthday, if you fall twice in the same year, you have a 50% chance of not seeing your next birthday. It's a very common thing that folks that end up with vestibular problems or balance problems, may not be vestibular, they fall, they break their hip, they go to the hospital to get pneumonia, and everybody starts saying nice things about them when they're gone. So, equilibrium is a sense of being in equilibrium is maintained by input from three systems. What our eyes tell our brain, what our bodies tell our brain, and what our vestibular system tells our brain. Visual system feeds information about our depth of field, where we are relative to other things in space, where our head is relative to our torso, where we are in relation to other folks. It's constantly feeding information to the brain about where we are in space. Our musculoskeletal system also provides information to our brain about where our head is, where our feet are, and where our rear is in relation to the rest of our body. And there's constant feedback from downstairs to upstairs that's telling our brain where we are in space. The vestibular system, located within the inner ear, my area of interest, is comprised of 5 sensors. So there's a max set, 5 on each side. There are 3 canals. And we have different names of the 3 canals. There's 6 names for 3 canals. I don't know why we come up with 6 names for 3 canals. I'm going to call them the lateral, anterior, and posterior canals. They're full of fluid. At the end of each canal, I'm going to simply describe as a gate. The cupula is there. Fluid displacement, pressure upon that gate, tells our brain the direction our head is turning. So the 3 canals deal with 3 planes of orientation. So when we turn our head to the right side, the fluid is displaced, causes the cupula to fire a signal to the brain, and tells our brain we're turning to the right, which then moves our eyes to the left. When our head is in motion, our eyes are controlled by our ears. And if our ears are not supplying the right information, our eyes don't follow the plan. So when we turn our head back and forth, our vestibular system moves our eyes to maintain a stable image while our head is in motion. When our head is perfectly still, we can look around the room and nothing is out of focus. But if you have a vestibular system error, when you turn your head back and forth, the world glides and it becomes distorted and we get a bad image. If things are working well, when we turn our head back and forth, the world stays in focus. And the semicircular canals are responsible for that. So they tell the brain the direction our head is moving. The otolith organ, located right up here, and I'll describe as 2 catcher's mitts. There's a lateral system, there's a vertical system. Embedded in that Catcher's mitt are little tiny hair cells. On top of that is a bed of jello. On top of that is a pile of calcium carbonate crystals. And they ride on top of that jello and feed information to our brain about the plane that our head is moving in and how fast our head is moving in that plane. By displacement of the otoconia, the rocks on top of the jello causes the hair cells to fire and tells us fore and aft, side to side, and up and down motion as the rocks sit on this jello and fire the hair cells. It's an amazing system that tells our brain about direction, plane, and speed of head movement. That then sends a signal to our brain to adjust our neck muscles over our torso and changes the orientation of our head in relative into space. So it's constantly telling our brain the direction and speed of our head movement. And it works fantastically well until it doesn't.
With kids that get concussions, Mike, do you see problems in the ear itself, or is that always in the cortex?
Commonly a cortex things. Kids are amazingly resilient. You don't get displacement of the otoconia with a head injury with a child as much as you get with adults. Why that is a good question. I don't have the answer. But kids don't get the otoconia, the rocks loose in your head phenomenon like adults do very commonly.
How about football players? Those guys who are adults and get head injury all the time.
There's a lot of research in that right now, a lot of research on concussions and the consequence to the vestibular system. We have some tests that we can do on the field of play for balance with athletes to determine whether they've had a concussion or not, but it's not really defined. We don't have really good definitions.
Soccer, these guys are hitting a ball with their head all the time.
If you hit it inappropriately, it's a problem. There is a good place, there's a sweet spot for hitting the ball with your head. As an adult, as a child, there's not a sweet spot for hitting the ball with your head, and that's why we've outlawed heading of soccer to children under age 12. So, in the United States, we've outlawed heading of the football, the soccer ball, below age 12. Particularly in girls. Girls have less strength in their neck muscles, and that has a higher consequence for head injuries for women. So girls have more opportunity for injury. I'm talking way outside of my area of expertise other than soccer. As a soccer coach, a soccer referee, and a soccer club administrator. So we talked about the two sensors, both the semicircular canals and the otolith with the otoconia. So here are things that go wrong. A lot goes wrong. Majority of the time, it's very self-limiting, but then there are other times that have long-term consequences. So you can have
Can you use a pointer?
Yep. You can have canal lithiasis, and that is just benign paroxysmal positional vertigo. I tell my patients they have rocks loose in their head. So the otoconia from a blow to the head can get displaced, and they then start floating around in the fluid of the semicircular canal, and then end up piling up against the gate, most commonly in the posterior canal right down here. So the particles live here. Once they get displaced, they, because of head movement, cause most commonly the otoconia to come down this canal and pile up against this gate. And so when you roll over in bed, the cupula gets displaced and it stops, but because of the weighting of the otoconia, puts pressure on the cupula, and that tells your brain you're still moving, and that makes your eyes move. So you look up at the ceiling, the world spins around. A quick, brief spin. You lay down in bed and roll over on your right side. You get a quick, brief spin. You look under a cabinet to grab something. You get a quick, brief spin. It's very disturbing to patients. And so patients will lay in bed semi-reclined for years because they don't want to lay flat in bed because of this problem. Most common is the posterior canal. The next most common is the lateral canal, or it was called the horizontal canal, and it is rare that it's the anterior or superior canal. It is common, though, that patients are seen by their primary care physician. They're then said, oh, do this head movement, do this maneuver, go home and do this head maneuver, and you can get it fixed. Patients go home and get the head maneuver, they're better for a week, and then all of a sudden, a week later, they start getting dizzy a different way because they've just displaced the otoconia and moved it to a different canal. So home treatment doesn't always work. There is a couple of very effective home treatments that I give patients to do that does work. But you've got to do it the right way, or you're just going to send it to another neighborhood and start causing trouble in that neighborhood. Vestibular neuritis is inflammation either on the superior vestibular or the inferior vestibular nerve. A virus attacks the system, causes inflammation around the nerve, chokes off data being sent from the vestibular system, and makes you spin like a top. And you can't get off the merry-go-round. At worst, it lasts for a month. At best, it lasts for a week. And the world spins around 24/7. It's a very, very miserable experience that I have the opportunity to learn to have some compassion for my patients by having it myself. Meniere's is the endolymphatic hydrops and a change in fluid pressure levels within the cochlea and also within the vestibular system. Causes a storm of spinning for 2 to 3 hours, and then the storm goes away. You're perfectly fine the next day after the system recovers. Vestibular migraines. 30% of all dizzy patients I see are migrainous patients. They are untreated migraines.
I didn't know there were two types of Meniere's. What's the distinction?
Type 1 is the short, the initial sides. Type 2 is long-term Meniere's. So untreated Meniere's, it goes into a daily chronic issue. Type 1 is a short-term, lasts for a day, goes away, and then progresses. And they're treated differently. Type 2 Meniere's, patients, they have to limit both their salt and sugar intake, but level it throughout the day. And typically salt is a troublemaker for type 1. Okay. Here's a classic fun thing I like to have my patients do. Look how many black dots are on the screen. And the answer always is there's no black dots. Your eyes are trying to fill in the information and put a dot where there is no dot. If you move your head back and forth, the dots move. Or they should move, or you need to come see me for a later. So the aging balance system, it happens as we get older, things change, our vestibular system decreases its sensitivity, our visual acuity changes, and our proprioceptive responses changes. And so I start seeing more and more patients with bigger birthdays. It's either the common things that occur with visual input losses. Proprioceptive changes is a very, very big problem with older adults that sit around and watch The Price is Right rather than going to yoga classes. The longer you participate actively in yoga classes, the more you are active, the better you're going to do. The more you sit around, the more the system deteriorates. Atrophy is a very common thing that happens as you get older with proprioceptive input. Very, very bad news. And the other thing is that the brain is constantly looking for data. And if you're not moving around, and you're not looking around, and you're not moving around, you start losing function. So as you can see with the aging vestibular system, we lose function there commonly with everywhere else in our body. So how do we check these things? Well, the biggest diagnostic thing that I find from a patient is their history. The patient fills out a dramatically complex questionnaire. I then spend 15 minutes talking to them about their questionnaire and getting the right answers. And by the time I walk out, 90% of the patients, I have an idea of what's going on. And so then I do certain tests to determine, to either confirm or deny what I think is going on. Many times I'm surprised to find what is going on, but we do different tests. Some are standard neurologic function tests. We have some fancy equipment that's very expensive and poorly reimbursed that we use to measure vestibular function, but also proprioceptive and visual function. So, here's posturography with a lovely spokesmodel of my wife standing on a platform. The walls move, the floors move, and I take a look at how the patient deals with challenges, perturbations at the feet, how they distribute their weight, what strategies they use to maintain their function is very enlightening for the patient. Here is video nystagmography. It's just infrared video cameras monitoring eye movement. We record the eye movement by putting them through different tests. Eye tracking tests, positional tests. We stimulate the vestibular system by putting warm and cool air in, changing the viscosity of the fluid within the horizontal or lateral canal. And by doing that, that changes the firing rate, which makes the fire faster and makes you spin like a top. But you don't know it because your eyes are covered. We can record your eye movement. Here's a fun example of an abnormal VNG, if I can do this. So this is a patient there. I take them away. Function there is a person with a tumor. So they've got a problem. You take away fixation, and their eyes start with a downbeat nystagmus. Video head impulse testing we've started using in the last few years. This allows us to measure the function, the high frequency function of all 6 semicircular canals. We jerk the patient's head back and forth in different movements and take a look what their eyes do compared to what their head does. So there's an accelerometer on the goggle body that measures head movement. There's a high-speed video camera that measures eye movement. We compare the two.
You have to have a bucket to collect the vomit?
The good news is I don't let patients eat for 3 hours before coming to see me.
That's a very good idea.
That's a big requirement that I have for patients. I had a 10-year record of no emesis that was broken a year ago by a patient that did not follow the rules. They swore they didn't eat, but then they admitted as they were throwing up. They did have a muffin and some coffee, which is very bad.
Yeah.
All right, here's a V-head sample. This is an amazing technology. We used to use a recording contact lens, electrode. So we put a contact lens or electrode on the patient's eye and measure this, which is not comfortable and is very expensive to do. And now we have this high-speed video camera that does the same thing and does a better thing. And however, we can't get reimbursed for it. Amazing, isn't it? So let me show you. Here is a recording of abnormal V-head. The eye should move straight across, and you can see it's taking a little dip. And it's also doing a jump. That's because of it's making a catch-up saccade. Their head moves, their eyes don't recognize the head's moving, and then makes a catch-up movement. That's because of loss of vestibular function. The lateral canal is not giving good information going to the right. And therefore, when the head moves, the eyes don't move in concert with head rotation. We do other tests. We take a look at the sternocleidomastoid muscle contraction when putting a loud, obnoxious sound into the patient's ear. We're just putting a pressure wave and stimulating the otolith organ. So we're stimulating the saccule, one of the areas where the otoconia reside. We're stimulating that by a pressure wave. So you can be deaf, and we can do the same test. This is just putting a loud, obnoxious sound in their ear and recording a muscle contraction of the sternocleidomastoid muscle. Folks that have problems are going to have reduced performance, as you can see, right versus left. There's a big difference in the amplitude of the wave that we're recording. And that helps us find out problems. So what do you do about it? Medication is rarely beneficial. Meclizine is just as valuable as 3 scotches. And you don't want to have your patient taking 3 scotches every day for 3 weeks. Maybe you do, but if it's bad scotch, you're just punishing your patient. So, meclizine is a neurosuppressant. It's not good stuff. It is a crutch. The longer the brain is not getting data, the longer it takes to recover. So why would you sedate the system that's trying to correct the problem? Prescribing meclizine is a bad idea. Making the patient miserable when they're moving around is a good idea, because the more they move around, the sooner that they get better. So I kick the patients off of meclizine, I get them out there and moving around in space. And I tell them, you're going to feel worse, but you're going to get better sooner. Dr. McBride.
What about motion sickness? Do you use it as a crutch for people who have that, or do you just tell them, too bad?
So if they have a problem with motion sickness, and that's a temporary thing, they can use that.
Okay.
But if they have a chronic vestibular problem, you're creating more problems than you solve.
Any benefit of the meclizine versus the transderm scopolamine?
There's an allergic reaction with one versus the other. Meclizine is less prone to problems. Scopolamine, ginger is better than the two of them. Powdered ginger capsules and dried ginger is a huge vestibulosuppressant.
That's why ginger ale makes you feel better when you're sick.
Ginger is a great thing, and the folks on Mythbusters proved my point. I was absolutely stunned that they did this test where they did the scopolamine patches, they did meclizine, they did the wristbands. You know, you see people wearing these wristbands. It's faith healing. Wristbands are faith healing. It's like ear candling. Doesn't do a thing. And Mythbusters did ginger and proved that ginger works fantastically well. I was just stunned to see that. Some friend had said, hey, you got to see this episode. So commonly we rule out other things that are causing balance problems, but we're 99% of the patients, it's an exaggeration, but my wife says I'm common to exaggeration. Physical therapy is the number one thing that helps get patients back in the swing. It may be a short education series, it may be a series of treatments in the office. But they've got to get the patient moving around and retraining the brain to substitute for lost function that's never coming back, but you can compensate for it, to help restore function, and to get the rocks loose in your head out of the way and get them cleared out of the system. Gaze stabilization therapy is phenomenally successful. I did it on myself, and it works. When I had a problem, I made myself worse by shaking my head back and forth and focusing on an object while moving about. It works very, very well. I was in Toronto last winter. We didn't come back with a cup, but the year before I went to Toronto, we came back with a cup. I hope to not have to go to Toronto this year and have a cup final in Seattle. That's my story, and I'm sticking to it.
Those very elegant tests that you described for balance disorders, pretty unique to your office, or are they offered here at the university or elsewhere?
Posturography is not available here at the University of Washington. They have it at Virginia Mason. They have it at the VA. I think they have one on the east side. The video head impulse testing I've had in my office for 3 years. I just convinced a colleague at the UW to start employing that, and he's having good success. That VHIT system is not commonly used in the area just because we can't get paid for it. Now, it's a $20,000 piece of equipment, you can't get paid for it. And I just do the test because I see so much value in the information I get. Other tests, one thing I don't have is a rotary chair. Because that's $120,000, and you get paid $100 for a patient 1 hour exam. So, and I can't have patients sitting on laps to make it pay for itself. but that helps. The V-hit gives me information that the rotary chair does not. But there's a rotary chair here that, but it's not, all that equipment is not commonly available. There's probably 3 places in the state.
It seems like the cell loss in the membranes that's damaged by noise, that may be a problem with stem cells that are, are there any animal models where they try to restore that with?
Stem cell treatment, I am unfamiliar with any current research in that area. May be occurring, but I'm not familiar with it.
Are there any forms of the hearing loss that have been attempted by stem cell replacement?
Not that I'm aware of.
I'm sure there are. Are all physical therapists trained to do these vestibular things? You have to find special physical therapists.
You have to find special physical therapists that specialize in vestibular rehab.
So up north where we are, is there somebody that you like?
There's a bunch of really good people up north. There's one really good person here in this neck of the woods in the Seattle area is Julie Grove. She's over in Leschi. I send her all my tough cases. So all my tough cases that Dr. McBride sends to me, I send to Julie Grove. So she's great here in Seattle.
Is it usual for audiologists to deal with vestibular problems as much as you do? Is it usually ENT docs who are doing it?
ENT docs are the least likely to be.
They're going to pass them to Mike, is what they're
Because we can't, ENTs can't do surgery on this.
I see.
And so they're not wildly interested in it. Probably 10% of audiologists have any expertise in vestibular patients.
So to be honest, you're pretty unique in this region for handling this.
Well, my wife says I'm unique for all kinds of reasons.
We don't have to get into that.
It's to have balance centers are uncommon. There's one, Virginia Mason has Swedish has a balance center. They used to have they had an otolaryngologist that just had to take medical leave, and I don't think that she's going to be replaced. But Dr. Jay Rubenstein at UW is doing research on vestibular implants. So that's one area of interest that holds some promise.
Well, thanks is one of the most valuable pragmatic talks of the year, because we, frankly, as MDs, don't learn any of this, or we learned it and forgot it a long time ago.
Thank you.
Complicated system. I remember the only time I've had vertigo, I was having heat prostration. I was on a trip in Japan.
Oh, yeah.
And my friends noted that I'd stopped sweating. And then the next thing I noted that I had to sit down because everything was spinning like a top. Is that part of the...
Very common, yeah. Dehydration is very, very common.
So presumably the fluid was getting low there? Or?
You can do this opposite thing by drinking too much alcohol. So then you get heavy water syndrome. And so that causes the same impact as having reduced hydration.
Is that why when you get drunk, which I haven't done, but the world spins?
Yes.
Yes?
So
it causes a change in the weight of the fluid within the vestibular system, and that then causes it to misfire. So when you lay down in bed, the world starts turning around.
Yeah, that's very unpleasant.
And then you can't get off the merry-go-round.
Yeah, that is
recall from college days.
One of the worst feelings in the world. I can't imagine people who live with this as a chronic disorder. It's just unbelievably incapacitating.
One of our fellows had that for a while, a couple times last year. That was very disabling.